possible. Finally, last but not least, we are fortunate and honored to have Mr. Evans Munuve join us as Program Lead Early Childhood Development. He's a member of the Division of Reproductive Maternal Neonatal Child and Adolescent Health. I understand that he is also an occupational therapist, and I trust he will be particularly interested by the orthopedic surgery work of Dr. Ngoku. If you have additional questions, please ask them in the chat, and they will be addressed either live, depending on time, or by email after the webinar. Special thanks to two young physicians from Indonesia, Dr. Arnetta Elena Puteri and Dr. Anissa Insani. And because this is so recent, Arnetta, I trust I might be one of the first one calling you doctor. And they are doing a fabulous job at organizing our webinars. Today, more than 350 attendees from many countries have registered, and a certificate of attendance will be provided after the webinar. I now have the pleasure of introducing Dr. Agustini Utari, who will be our chairwoman today. Dr. Utari is also vice president of GPED. She's a pediatric endocrinologist from Diponegoro University, Semarang, Indonesia. She holds a master's degree in genetic counseling. She did a year of research fellowship on Fragile X syndrome at the Mind Institute in the USA, and she obtained her PhD from Nijmegen University in the Netherlands. She currently serves on the National Newborn Screening Committee in Indonesia. Dr. Agustini, the floor is yours, and thank you for accepting to chair this meeting.
Thank you, JP. Good morning, good afternoon, and good evening, everyone, and welcome to the GPED Wishbone Day webinar. My name is Agustini Utari, and I'll be your moderator for today's special event in recognition of Wishbone Day, the International Awareness Day for Osteogenesis Imperfecta, or OI. Wishbone Day is not about fundraising, it's about shining on a light on awareness, education, and empowerment for individuals living with osteogenesis imperfecta and the healthcare professionals supporting them. Today's webinar is hosted by Global Pediatric Endocrinology and Diabetes, or GPED, as part of our commitment to equitable care for children with rare bone disorder around the world. We are joined by a remarkable panel of experts and advocates from across the globe. To start us off, it is my pleasure to introduce our first speaker, Dr. Maria F. Robinson, who will be sharing insight on current best practice in osteogenesis imperfecta care. Dr. Marie F. Robinson is an assistant professor of pediatrics at the University of Ottawa and holds a research chair in genetic skeletal disorder. She is a pediatric endocrinologist specializing in metabolic and genetic bone disease and conduct research at the CHEO Research Institute. Her work focuses on improving outcome for individuals with bone disorder, especially osteogenesis imperfecta, through patient-centered research and precision health approach. She is also active in global outreach to improve care for children with bone disorder in countries like Ecuador and Haiti. Dr. Maria F., time is yours.
Hi, everybody. It's a real pleasure for me to be here. I'm really delighted to see so many of you online. Okay, so as we discussed, I'm going to talk about the current best practices in osteogenesis imperfecta with a focus on how to do that in resource-limited setting. Those are my disclosures. So I have three objectives for today, hopefully that we can achieve. And throughout my talk, I've integrated the questions that were submitted by you so that we can really focus on what your needs are. So you'll see that throughout the talk, you might recognize some of your questions. So first objective is to help health professionals recognize and diagnose OI. Then we're going to talk about the importance of intravenous bisphosphonates. And as Dr. Shenwanse said, this is an extremely important drug for OI and is the standard of care for children and adolescents with OI. And then we're going to talk about how you can safely prescribe bisphosphonates in OI. So first, talking about how to diagnose OI. So when we think about OI, it has a huge range of severity, but the hallmark of OI is bone fragility. So that means children or adults are having fractures without a significant trauma. So we call those low trauma fractures. So although all children with OI have bone fragility, the severity is very, very wide. So you could go all the way from a type 1 or mild OI, which typically those children look like quite normal. They might have slightly reduced height. They have fractures. They might have mild bowing, but otherwise are living a pretty good life. And then you have the type 3 OI, which is the more severe type out of the ones that are surviving the neonatal period. And so as you can see in this little girl here, typically in type 3 or severe OI, children are wheelchair bound. They have severe short stature, severe scoliosis, bone deformities requiring orthopedic care. You're going to hear a little bit later today. And then type 4 OI, that's the moderate type. So this is the severity between type 1 and type 3. So those individuals typically need some form of mobility aids, but are able to ambulate. They have moderate short stature, fracture, scoliosis, bone deformity, but in a moderate sense. And then type 2 is the lethal form. So to be able to diagnose a child with type 2 OI, unfortunately, that individual has to have passed away. So we're not able to diagnose type 2 until it has shown to be lethal. So any survivors is therefore called type 3. The reason why OI can be lethal is that when OI is so severe in utero, the chest size is very small because the ribs are so thin and the fractures of the ribs are so severe that the lung are not able to develop, and therefore those children have lung hypoplasia and they pass away of respiratory insufficiency. So that's why lethal OI can be lethal. I want to make the point that came up as a question as well, is that OI is a clinical diagnosis, meaning you don't need a genetic mutation to confirm a diagnosis. You can make a diagnosis based on clinical features of bone fragility, and then depending on the type, but you don't need a genetic mutation. The field is moving away from using the OI type 1, 3, 4, and 5, and so on, because it has become quite complicated because there's so many genetic mutations now causing OI. So we're really now just using the terminology, which is mild, moderate, or severe. So mild was type 1, moderate type 4, and severe is type 3. And so you could have different mutation and you could still label them as mild, moderate, or severe. So that's really the way that the field is moving in terms of labeling the types of OI. OI can be dominant or recessive. I'm not going to spend a lot of time there, but just making the point that the vast majority of OI is caused by mutation in type 1 collagen gene. So that's the gene that's coding the collagen. And so you can have mutation in COL1A1 or COL1A2 as the most common types of OI, which is a dominant form. So when we think about collagen, so collagen is everywhere, right? So it's obviously you will have a bone phenotype in OI, but because collagen is everywhere, children with OI typically have other manifestations than just the bones, and those could be helpful cues in the clinic, especially in milder form where you're trying to discern if that's OI. Now we have to remember though that you don't need to have those features to be able to make a diagnosis, so they're not always present. But the main feature that you can see is the blue sclerae. And you really need to have natural light to be able to determine this color of the sclerae. And that's because collagen is in the sclerae. That's why you see this blue hinge. Scoliosis, and that's because of the ligament issues in OI. Ligamentous laxity, which basically means that you're hyperflexible in various parts of your body, can be the fingers, the elbows, the knees, the ankles. So that's something you always want to check in your examination. And then the dentinogenesis imperfecta. So that's because dentin is abnormal because of the abnormal collagen. So those individuals will have gray teeth. They could be fractured, discolored. And interestingly, this is really something that's more severe in the primary dentition. So children that have not yet their adult teeth will appear way more severe in terms of their dentinogenesis imperfecta than the adults when they have their permanent dentition. But it's always important to look into the mouth for OI. So when you have a child for which you have a clinical suspicion, so a child that has a history of low trauma long bone fractures, and how do we classify or how do we define low trauma? Because sometimes it can be hard in the milder form of OI to say if this is a low trauma or not. So whenever you have a child or an adult that fractures a bone at no more than a walking speed, so basically the person is walking only and not running, or if they're falling at no more than a standing height. So if you have someone that's walking, falling from their own height and having a fracture, that's never normal. So if you have this, that's when you want to start your workup. And if you have those extrascatal signs pointing towards a collagen type 1 mutation, you can also have extra clues. But as I mentioned, you don't need those to be able to say that this is OI. So the most important test to do if you have clinical suspicion of OI, if you had to pick one single test, especially if you don't have access to a DEXA, and I'll talk about that, but this is a lateral spine X-ray. So a radiograph of the spine looking laterally. And that's because you want to see if there are vertebral fractures or collapse of the vertebral bodies, because this is an indication for treatment. If you have access to a dual X-ray optometry, that's great to look at bone mineral density. Blood work are important to do, especially to rule out rickets or vitamin D deficiency, which could lead to bone fragility. If you have the ability to do an X-ray of the growth plate, that can also be helpful to rule out rickets, which can sometimes show with simply bone fragility. So that's the reason why we like to have a growth plate X-ray. If you have genetic testing, that's good, but you don't need genetic testing to make a diagnosis. And you also want to exclude secondary osteoporosis. That's more so in the case of milder OI. If you have a very severe case or something that presented in utero, secondary osteoporosis is not on the table. But you want to exclude secondary osteoporosis in milder form, and that could be, for example, ruling out celiac disease, ruling out leukemia, if the patient's on steroids. Those are all things that could give you osteoporosis or bone fragility. So I talked about the importance of a lateral spine X-ray. So I just want to say a brief word about this. So this is a spine X-ray looking at, so laterally, and you see here, this is a normal film where the vertebrae here, they're this kind of square shape. So you have very nice and tall vertebral bodies. And what we want to see in that when you do your lateral spine X-rays, you want to look at vertebral fractures. And there's a classification to look at vertebral fracture where you can grade them as mild, moderate, or severe. But that's not so important. What's really important is to be able to say if there's a fracture or not. And we can say that whenever you lose height in your vertebral body. So whenever this vertebral body is less than 20% compressed, so you're losing more than 20% of your height, this is a fracture. So on the right panel here, you see example of vertebral fractures. So you see how instead of being this nice square shape, the vertebrae is now compressed. This is a severe fracture. And that's a sign, obviously, that you have to intervene fast to protect that spine. So that's why we really need to have this spine X-ray as your single most important test. If you have access to a DEXA, that's great. So that's the way to measure bone mineral density through this machine. That's called a dual X-ray optometry. The consideration to have when you do a DEXA is that the DEXA is a two-dimensional measure. That means that if you have a shorter bone, the machine will interpret that as a weaker bone or as a bone that has less bone mineral density, even though it can have the same density. So this is an example here. If you were to take a DEXA of this size here, you would have the actual same density by the machine as a taller bone that has the same density. And that's just because you're only seeing this in 2 dimensions. So that means that you have to be careful when you examine a DEXA in kids that have short stature. And that's often the case in OI. So when you have a child with OI that have short stature, you have to look at the score obtained from the DEXA and compare that to their height, because you could have a score that's falsely low because of their short stature. In kids, the software that you get from the DEXA typically will give you a Z score. That's basically a score that is adjusting your result based on the age of the child and the sex. So it's going to give you a result for a given age. So let's say a 3-year-old, a similar girl of 3-year-old, for example. But if your patient is short for their age, that's when you need to adjust because you might have a falsely low bone mineral density. So I talked about how the most important tests, so blood work, DEXA, a spine X-ray. But we got a really interesting question from the audience that I want to highlight here. There was a question about how to diagnose OI in utero, and that's a really tricky thing to do. And that can be hard to do, especially if you don't have access to in utero genetic testing, which of course makes the diagnosis easier. So I'll show a case of in utero OI, but my point here is mortality cannot be predicted from an in utero ultrasound. And that's really important. So the only way to know if a child with severe form of OI will survive is, as I mentioned, is the postnatal course. And that's important because sometimes a physician can actually predict mortality when it's actually not a lethal case of OI. This is what OI can look like in utero. So I'm showing here one of my patients that those are a 20-week prenatal ultrasound. And here you have 20 weeks. So what typically is seen in the setting of OI, they can have here in this instant a normal chest, or in very severe OI, they can have a small chest. But the typical feature is the bowing, right? So you will have, here is the femur. You see how, sorry, the femur is here, the right femur. You see how it's completely bowed. This is a tibia, so very significant bowing. So that's one clue that you can see on ultrasound. The other clue is the femoral length to foot ratio. So that's basically saying that usually a fetus should have the same length in terms of a femur and foot. So the femur should not be shorter than the foot. But often in case of OI, the femoral length would actually be shorter than your foot length. And that's when that's a red flag. Usually they'll have normal growth interval as well, and normal mineralization, although that's sometimes a harder one to make. You could also have low mineralization as per the radiologist. But bottom line is, it can be hard to differentiate a skeletal dysplasia from OI or another type of skeletal dysplasia than OI. And again, very important to not predict lethality. This is the same child, and you see that had quite a severe phenotype in utero. When this child was born, that was the chest, so slightly thin rib, but overall normal chest size, but quite thin skull, significant plagiocephaly. This baby needed to be intubated at 1 day of life, but we were actually able to extubate her at 1 week of life. And this is her now. So this is her at 1 year. You see how initially when she was born, her bones were very heterogeneous. There was fractures, very bowed. And now that's on therapy. On bisphosphonate, you see how the bones are actually looking pretty good. Obviously, there are still fractures, but this is her bone mineral density here on bisphosphonate. So you could see that's a bone mineral density chart. So this is the age on the x-axis, the density on the y-axis, and you could see that this patient that had quite severe phenotype in utero has normal bone mineral density and is actually doing quite well, but she was diagnosed with a severe OI or OI type 3. Another question related to diagnosis that was asked was, how can general practitioners diagnose OI, or what can they do to diagnose OI? So I think that one key for general practitioners is to not miss the individuals that have low trauma fractures. So if you have a child that is presenting with a fracture without significant trauma, that's never normal, and that deserves a workup. And usually the family doctor can potentially be able to do that spine X-ray assessment to assess for vertebral fracture and exclude rickets. But management of OI is quite hard to do for a general practitioner because you need typically a setting where you can administer an intravenous drug, which can be challenging to do. And I'll go over the treatment later on. So summary, so you'll have little summaries throughout my talk, but first is OI is a clinical diagnosis. You don't need genetic testing, and you are classifying OI based on phenotype, mild, moderate, or severe. And the lethal form is really only diagnosed in postnatally and whenever infants don't survive. So now I want to talk about the second objective, which is bisphosphonate, and how key bisphosphonates are and how they are standard of care and should be absolutely available if needed. So who do we treat with bisphosphonates? I'll start with that and I'll go over how do we treat. So you want to treat as early as possible in OI. As soon as you have a patient with even just one vertebral fracture, that's when you want to start therapy. Or if you have a child with a significant low trauma long bone fracture. What is that? So basically, if your patient had a humerus or a femur fracture, just one fracture, you start therapy. You don't need more than one significant fracture because a humerus and a femur is very hard to break, and that is a sign of a significant bone fragility. If your patient's fracturing other long bones than a humerus or fracture, so for example, a radius fracture, a tibia fracture, those are easier to have. And typically we will wait a little bit more before treating. So usually we wait for 2 or more long bone fracture per year for 2 years. And that's because in very mild form of OI, we actually don't want to treat if it's not needed. And the second indication outside of bone fragility is pain, because bisphosphonates are very helpful for pain. They're like a Tylenol for the bones. So if you have a child with OI, even if they're doing pretty well from a bone fragility perspective, you can decide to give bisphosphonates to help with their pain. How do we treat OI? So I'm going to focus my talk on bisphosphonates, but bisphosphonate is one piece of the puzzle. OI is a multidisciplinary treatment approach. One piece is bisphosphonate, I'll focus on that. The other huge piece, which we'll hear about today, is orthopedic surgery to correct deformities, right? You want to put rotting telescopic rods for deformity to correct scoliosis, and rehabilitation, occupational therapy, physiotherapy. We'll also hear a little bit more about that later. So I'm going to focus on bisphosphonates because that's really the important key point I want to drive. What are bisphosphonates to start? So here in this upper panel, I'm going to show how bisphosphonate work, okay? So this is a typical bone. So usually in the bone, you have those large cells, which are osteoclasts, that are chewing up the bone, resorbing the bone. Here in green, this is the mineralized bone shown. And here is the osteoid cells, which are laying new bone. So usually you have this balance of new bone being laid by the osteoblast, old bone being chewed by the osteoclast, and you have this balance between the two. When you add a bisphosphonate, you intoxicate the osteoclast. You make the osteoclast inactive, no longer able to resorb or chew the bone. So the net effect is that you'll have less bone resorbed or more bone left because the osteoclasts are no longer chewing up the bone. So that's how bisphosphonates work. They're intoxicating the osteoclast, and stopping resorption. The key thing is bisphosphonates, and that's why we like them so much, is the attached for the skeleton for 20 plus years. And that's what we want in OI, because OI is a genetic condition. The bone fragility will remain all their life. So we want to have a therapy that has a long-lasting effect like bisphosphonates do. Another question from the attendees were, which bisphosphonate is better for children with OI? Should it be IV or oral? It's IV. So oral bisphosphonates should not be used in children with OI. They can be used in adults, but not in kids. And that's because oral bisphosphonates are not strong enough, not bioavailable enough to protect the spine. They're not able to heal vertebral fractures or to protect new vertebral fracture from happening. So we never use them in growing kids with OI. What are bisphosphonates doing? They do a lot of really important things. I have a slide here summarizing their benefits. What they do is they increase bone mineral density by the mechanism I showed you on the cartoon. They reduce the amount of long bone fracture a child will have. So this is prior to bisphosphonates, lots of fracture shown by the arrows. After bisphosphonates, less fracture. Kids with OI still fracture with bisphosphonates, but halfway, so it's 50% less. So that's a huge, huge benefit for them. But the most important thing that bisphosphonates do, they protect the spine. So this is an example of a 3-year-old. That's a lateral spine X-ray. You see those vertebral body, as I showed you before, they're collapsed, they're fractured, severe fractures. And when we gave this child bisphosphonates, you see how the vertebral body fully reshaped. And that's very important because if you don't protect the spine in OI, you can end up with severe lung restriction because of kyphosis of the spine from vertebral fracture, severe pain, you lose height. So protecting the spine is very important, and bisphosphonates do that extremely well. They also reduce pain. This is the child before bisphosphonates and after. And they also increase grip strength, so they improve muscle. This is unpublished, but we have also showed that bisphosphonates also improve height. So if you look at the Z-score of height and you look at bisphosphonate treatment before and after, you actually have a better Z-score of your height in all types of OI when you treat with bisphosphonates. And this graph here shows that the earlier you start, the more effective of height you have. So just to give you a sense, if you have a girl patient with OI type 3, bisphosphonate will give you about 11 centimeters more of height. Another question that what came up multiple times from the attendees was, should I use the lindronate or pamidronate? They're both IV drugs, so they're both okay. Bottom line is you could use either whatever is mostly available to you and easier for you to give. They're both protecting protecting the spine and preventing new fractures in the same way. So the efficacy is the same in terms of fractures. Zol is a little bit better in terms of increasing density because it is more potent, but there are still two very good drugs that you could use depending on what's available. The main difference between Zol and pamidronate is that zoledronate is given less often, so 6 months as opposed to 4 months, and it's given on shorter periods. So each infusion cycle is only 50 minutes. Pamidronate typically is given over 3 days, and each infusion is 3 to 4 hours, so way longer. The dose is slightly different, but if you are to look at the hospital visits, if you are to admit when your patient is receiving, you don't have to, but it's basically longer to give pamidronate because each cycle is a 3-day cycle if you use the full dose protocol. But again, they're both totally efficacious in OI. So how do we treat? So we use intravenous bisphosphonate, as I said, standard of care in any patient that has either vertebral fracture or a significant fracture history. Before starting your bisphosphonates, it's very important to always make sure you have a normal calcium and a normal vitamin D and a normal creatinine. And that's because bisphosphonate will lock the calcium in the bones. So if you don't have a normal calcium or vitamin D to start with, you're at the risk of having severe hypocalcemia. And I've seen really terrible case of seizure and from hypocalcemia happening because the pre-blood work were not done. There was another question from the audience asking, is there any micronutrients or minerals that should be given to children with OI? Vitamin D and calcium, that's the main thing. And you can get those with a diet alone as long as you have enough. So dietary calcium is always best. Typically, we say 3 to 4 dairy servings per day. You have the exact number of milligrams here per age. If you're not able to achieve that, you could give supplements, but diet is always better. It's better absorbed. And vitamin D, again, if you have enough, because there's enough in your diet, that's okay. But typically, you might need to have extra supplemental vitamin D. The rule here is that if you have access to vitamin D level, you want to have a level above 50 nanomole per liter. So you can give supplements to achieve that. If you don't have access to levels, you could just decide to start all your children on vitamin D if that's accessible between 400 or 1,000 international units per day. I want to talk about this case here just to illustrate. So I've talked about how important it is to start bisphosphonates early, and this is a really beautiful illustration of this. So this is a girl that presented, I saw her first at 15 months old, but she had presented at her initial institution at 5 months old. And at the time she had a fracture, a femur fracture. So here you have a lateral view of the femur. So femur fracture while pulling to stand. So that's never normal, right? Femur, low trauma femur fracture, you need to start right away. That was her spine at 5 months. So she had a normal spine. So see how those vertebral body are nice and squared. But because she wasn't started on bisphosphonates right away, this was her spine when I met her at 15 months, severe vertebral collapse. So this is to make the point that you need to really start bisphosphonate as soon as possible to protect the spine. And there was one very important question that was asked was, as how often can how early can I treat? And the answer is as early as possible. So yes, you can give it infants. As soon as renal functions normal, you can give bisphosphonates. There was a question about the frequency of zoledronate. So usually in infants, so typically zoledronate is given every 6 months, and you can take a screenshot of this. This is the Shriners-Montreal protocol. But basically, when your child is less than 2 years, you want to give it every 3 months. When they're over 2 years, you can give it every 6 months. And you want to adjust your dose based on your bone mineral density test. So here, if you have a bone mineral density test that's above -2, you will actually start to lower your dose. And if you have a score above 0, you lower even more. So you adjust your dose based on the DEXA score if you have access to a DEXA. If you don't have access to a DEXA, we'll go that slightly in 1 minute, but then you want to keep your regular dose of 0.05 milligram per kilogram per dose every 6 months. Pamidronate, that was another question. How often should pamidronate be given if you have pamidronate? For infants less than 2, and again, you can take a picture of this, it's every 2 months, and when they're over 3, it's every 4 months. And whenever you have bone mineral density that has normalized, you can actually do a short pamidratinate schedule, which is basically given 4.5 milligram per kilo per year. And you could give those as one single infusion as opposed to the 3-day infusion. So that means that you will give 1.5 milligram per kilo per day as a single infusion every 4 months. So you can save some time there if the patient has a normal density. So almost done here. There was a case about a question about how should I manage OI type 2 or lethal OI. This is just an example of one of my patients that passed away, but you could see this patient was born very thin ribs, ribbon-like ribs, lots of rib fracture, small rib cage, very severe plagiocephaly. His skull is very thin, very heterogeneous bones. The bottom line is even if you think that OI would be lethal, please still give bisphosphonate if they're available, because this is an extremely potent pain medication for those children that are suffering significantly from their fracture. So you want to give bisphosphonates early. This patient has passed away at 16 days of life on CPAP, and that's when we made the diagnosis of OI type 2. So you want to treat the pain, you want a gentle handling, and you could still do light casting if just for comfort if you need, but you really want to make sure it's light and not a heavy cast. So treatment of severe OI prenatally versus postnatally. So the bottom line is when you treat OI, even if it's lethal or not lethal, you have those important things like bisphosphonate, safe handling, respiratory support, and you want to make sure you do cluster care to let the healing happen. So cluster your care in the NICU. You can take also a screenshot of this if you want. This is just little tips on how to position infants with OI. So that can be given to nurse, and the OIF has really nice resources about this. So how to position, how to change a diaper, how you want to never have the spine that's over the spine, the head that's over the spine for positioning, because that could lead to more vertebral fractures. So you want to have them lying down, and you want to breastfeed while reclining as well. You want to treat, that was another question, you want to treat until the end of growth. Yes, 1 minute, perfect. Okay. You want to treat until the end of growth. That's really important to not do any drug holidays. And the last slide I had here is about this really important question of how can I basically treat and monitor my patients when I don't have bone mineral density available. So the bottom line is DEXA is used to safely administer bisphosphonates. It's not a measure of efficacy. So you want to use a DEXA to make sure you're not over-treating. So if you don't have a DEXA, you want to make sure you're looking at signs on your x-rays that you don't have over-treatment. So like sclerotic bands, or here you have very wide metaphyses, or bone within bone, which is a sign of over-treatment. And you could also have what's called a digital x-ray radiogrammetry, DXR, which is a hand x-ray that you can use to estimate your bone mineral density. And you could have software that are used to actually derive that correlate really nicely with DEXA. So that was the last kind of very important question. So I hope that was helpful, and we'll take a question at the end. Thank you so much.
Thank you so much, Dr. Robinson. That was informative and powerful presentation. And if anyone has questions, please drop them in the chat room, and we'll get them during the Q&A. And we will go to the next speaker. I'm pleased to introduce the next speaker, Dr. Lucy Mungai. Dr. Lucy Mungai is a pediatric endocrinologist trained at the University of Nairobi and the University of Barcelona, and was the local founder of PEDCA and ASPE. He has led national and international efforts in diabetes care, including the development of type 1 diabetes guideline, and as the lead of Pediatric and Adolescent Endocrinology Fellowship Program at the University of Nairobi, she has helped train future specialists. Through international collaboration, she has secured free insulin metabolic disorder treatment and screening program for children across Kenya. So, Dr. Lucy Mungai, time is yours.
Thank you very much, Dr. Agustin. Can you see my slide?
Yes, we can see that.
I have only 10 minutes, so I have very little to say, and I think much has been covered by the first speaker.
Okay.
So I'm going to say what we do in Kenyatta, how to make the diagnosis the same, that we usually take the history from the patient, from the guardian. Most of the children that we get in pediatric, they are really very small. Most of the children that we get are less than 2 years. Then we have physical examination, laboratory test to rule out other condition. And then we do radiology to be sure how bad the fractures are. When you're examining the patient, we usually look at the eye. Most people looking at this eye, they think the eye is very beautiful. And if somebody is thinking about osteogenesis imperfecta, they will see actually the sclera is blue. And we do the radiology. These are the kind of X-rays that you are expected to see, and we have seen it even in the first presentation. So what do we do with the patient? We make sure that we reduce pain in this patient, immobilize the affected bone, zoledronic acid, orthopedic review, and follow-up. Now, if we can manage the pain, we can immobilize the bone, and zoledronic acid in our center actually is usually bought for patients who have cancer, patients with problems of the bone. Actually, it is not, that's what it comes. Like now, this week we have free zoledronic acid that is available for free for patients, because there is a team that have donated medication for cancer patients, and it came with zoledronic acid. So currently we have zoledronic acid available in the hospital. And then after that, we refer them to the orthopedic surgeon to help us with the bones. They will come to the ward, they will review the patient with us, and then we agree on what we are going to do with the patient. But then I was going through to check how many patients that we have had so far. Between 2022 and 2024, we had 46 cases of osteogenesis imperfecta admitted in the hospital. In 2024 alone, we had 21 new cases, but then we had 5 readmissions from these new cases. And among these 21, only 6 came for the clinic. So I was interested, where do our patients go? How come they are not going back? Then I look at this study by Mwagi et al., who did a study in the Cure, one of the Cure, at the AIC Cure Children's International Hospital in Kijabi. And what I saw is that they have mobile clinic all over the country. They have about 15 mobile clinics in the country. And you can see we have from Mombasa, which is 500 kilometers from Nairobi. And then we have Trans Nzoia, and that is another 500, almost 500 kilometers from Nairobi. So they have this clinic that they are doing that are mobile, so the patients have access to them. And then, so I was looking at this. So how many patients are there? So you can see in Mombasa, 1 dot is equivalent to 2 patients. So we can see majority of the patients are actually in Machakos, where Lewis and his team are. And then we have another lot of patients that are found in central part of Kenya. The rest are scattered all over. They are scattered all over. And you can see like maybe the other people, the ones in Turkana, Marsabit, have not managed to reach us, the ones in the northern part of Kenya. But this gives you a description of where they are. So when you're looking at this paper by Mwagi et al., we saw that the patients that are, with the minority of the patients are between 0 to 5 in that study that he did, because he was looking at the patients they had seen from 2000 to 2014, which was 14 years, and they had seen 80 patients. And you can see that between 6 and 10 years, there were 20. Then by teenage, they were 25. And then looking down, you can see these patients are not reaching adulthood. They go decreasing now after teenage. It would be very good to know, where do these patients go after they reach teenage? Where are they? How come we are not seeing them? And then from his distribution of the patient that they see, we can see that he were from Kambani, where they are Kamba, the tribe, where in the area, in the location of where the Machako Center is. Then from the Kikuyu community, we had 24. That is about 30%. This calculation that they had done, I don't think is correct. But you can see the kind of distribution that you have. There are two communities that actually have the condition. So it would be good to do a proper study and checking these patients and checking where they are, calling them and checking where they are and seeing what they are. So this is checking in Machakos. How many patients had come from Machakos now? You see there were 21, Kiambu there were 24. So we have the Kikuyu and the Kikuyu and the Kamba distributed in other counties. And you can see in Mombasa there were 2 patients from there. And you can see where the patients are coming from. So if you look at this patient who was admitted in Kenyatta, this was a teenager who was admitted in the ward at that particular, and he was saying, I do not want to be there. Mwag said of his condition when the nation team, that the newspaper visited him in the hospital. I would like to be in school. This condition is not good. It's not anybody's wish to break a leg. It can happen to anybody. His mother said, Mwangi was the only one in the family with the condition. All his siblings, including a set of triplets, all are fine. So it would good to know that in our community, sometimes we think there is witchcraft, there is something, a mistake, somebody has committed a mistake, that's why the family is having children like this. And this requires a lot of community education. There's a lot of education required to do genetic counseling, and creating awareness in the whole country, like we have done with diabetes. How do you confirm, is the genetic mutation we are having in Kenya the same as we are having in Indonesia, the same as the one we are having in Canada? It would be good to do a sample of these patients and check what you have. When we did a study recently, this was on Hunter's syndrome, and this was a family that was struggling because they had lost 12 boys in the family. And actually, and you can see this family from that is on the right. They lost all the whole family was wiped out because all the boys died and the family had the condition. So the patient that came to us was this patient number 50, participant number 50, and you can see the mother had lost 2 boys already. And we checked the carrier among the relatives, and we could see that we have these cousins who are carrying the conditions, and then we were able to pick also another cousin who had the same condition. It would be good to know, how do you stop the burden of osteogenesis imperfecta in our setting if we are not checking the carriers? Because the carriers, they need to know they are carrying the condition. They decide whether they are going to get the children and whether they are going to get adopted children. And then we know whether it is autosomal dominant or it is autosomal recessive. It would be good to do this study and check what we are. Thank you.
Thank you. Thank you very much, Dr. Lucy.
Yes.
This very nice presentation. And today we will continue with the next speaker, Dr. Louis Nguku. Dr. Louis Nguku is a Kenyan orthopedic surgeon with expertise in clinical care, surgical training, and health system strengthening. He earned his orthopedic surgery training at the Macquarie University, and he is a fellow of the College of Surgeons of East, Central, and Southern Africa, or COSEXA. He currently leads the Machakos Orthopedic Clinic and has played key roles in establishing Kenya's first national joint registry and training program at IEC Cure International Children's Hospital. Dr. Nguku, time is yours.
Thank you. Thank you to our moderator. Well, everybody, good afternoon, good morning, good evening, depending on where you are. Allow me to just go through our experience in Machakos with osteogenesis imperfecta. So in our discussion today, I'm hoping that we can be able to talk about, just minimize this, we can be able to talk about our clinic, our story with bisphosphonates, what we usually do with the patients when they come to us, the challenges that we have had over the time that we've been doing this, and maybe share a few patient stories so that we can see the benefit of all this that we are doing. So for the sake of those who are around the world, this is where we are presenting from. We're in Africa, right about the middle of Africa, in Kenya. And in Kenya, we are running this clinic called the Machakos Orthopedic Clinic, which is located in Machakos. Dr. Lucy has just mentioned about the prevalence of this disease around central Kenya in Machakos, Kiambu County. Those are parts of Kenya that are right in the middle, and we happen to be just about at the heart of it. The clinic has been running for the last 10 years, and so this has been just about the time that we have been handling these patients. And so our story starts actually at the very beginning of the clinic in 2015. So we started our clinic in 2015, August. And in the same year, September, we got our first patient with osteogenesis imperfecta, born in a hospital that is nearby. We were called to review. And so we happened to see the child with a fracture femur on day 0 of birth, of life. Now, during the period of 2015 to 2018, we did not have access to bisphosphonates. And so most of the treatment just centered around surgeries. And the trouble is that now the patients would end up having frequent fractures. And so they have to just keep getting admitted to hospital over and over again. But then something nice happened in 2017. 2 children were picked by a missionary from Kenya and taken to Korea for surgeries. They had osteogenesis imperfecta. And after the surgeries, they were sent back to Kenya and were sent to us to give them pamindronate. And so they were also given the pamindronate to come with. And we realized that as we were giving them the drug, we had more than was enough for 2 patients. And so we asked the person who brought them to us, is it possible that we can use this same drug for the rest of our patients? And we were told, yes, go ahead. And so in 2018 or so, we started using pamindronate on some of our osteogenesis imperfecta patients. And immediately we started noticing differences because across the 6 patients that we had for a period of about 2 years, there was only one fracture that was reported during that time. And so I guess the rate of admissions started
Excuse
going
me,
down.
Dr. Nguku, I think this slide is somewhat is like stuck. Can you
No.
the slideshow maybe?
Can you see that?
We can see that, but it's not moving. Can you maybe try one more?
I have got out of the presentation.
Yeah, you can put you can go to the slideshow.
You okay with you can see that?
Yeah, we can see it, but it's not slideshow yet. So maybe you can go to the Boknia here. Yeah.
So you want me to keep it that way? I can.
Okay, if you cannot, I think it's better. But can you try to the next? Is it work or not? Yeah.
This one will
okay.
move.
Yeah.
We can just keep it just
Still
that
not
way.
in the slideshow, but it's okay, I think.
Okay, that's fine. Okay, so in 2018, okay, so in 2018 we started giving pamindronate to these patients, and we noticed the difference: the reduction in fractures, the reduction in bone pain. But then COVID came along. It became difficult to get the zoledronic acid, to get the pamindronate, and because of these issues with supply chain, the drug availability in the country was on and off. And so with collaboration from our friends in Canada, we were able to finally start getting zoledronic acid. And over the period from 2021 to date, we were able to recruit over 60 patients. I think our current number stands at about 74. And we have progressively seen changes, which I'll keep talking about as we go along. The challenges that we had received along the way, as I mentioned, during the time when we were just doing surgeries, it would be a significant financial burden to the patients because the parents have to keep coming to hospital. It was costing them a lot. The national social insurance was not covering for most of that period, it was not covering the treatment. And so it was a significant burden. When we started giving them pamindronate, yes, it was a good thing, but then they needed admission 3 or 4 times a year. And every time they were admitted, you would have to keep them in hospital for about 3 days because there's a day of admission and giving the drug for a period of 3 days. And you can imagine pamindronate is given for a period of about 4 hours or so. And so it was a significant inconvenience. In fact, I remember at some point the mothers of the children started saying, we are not going back to that hospital because it was just too difficult. And so when we were able to get zoledronic acid into the picture, the patients now no longer needed admission because they're only at our clinic, because now we give it at the clinic, they're only at our clinic for about an hour or so, where the IV line is put and they're able to be given the drug. The challenge has been that the zoledronic locally, the supply is unstable, and so we are still significantly depending on the drugs from abroad. And so the procedure, we just divide it into 2 parts. There is a part that is covered by the non-clinical people, and there's a part that is covered by the clinical people. So the non-clinical people will receive the patient in the clinic, they'll retrieve the record, and then after that, the clinician picks up, they'll insert the IV line. We have a sheet that usually has the patient's record and their calculation of how much drug they need to give. They'll be given the drug as per their record, and then after that, remove the IV line. The protocol that we are currently using is the one that we got from BC Children's Hospital, and we've been using for the last since we got the zoledronic acid, so that's about 4 years or so now. And these 2 children are sitting in the clinic having the drug being administered as they tell stories to each other. And so what we've just done is we've not even converted an area into a ward. They end up using part of the consultation room because they will come in reasonably small numbers sort of throughout the year. Most of our patients, as Dr. Lucy has already mentioned, most of our patients come from around Machakos. Of course, we'll have a few from other places, but then there's also a large number of patients who will also come from the mobile clinics that are conducted by our partner, Cure International. And because Cure gets to see children, pediatric orthopedic patients, and therefore children with osteogenesis imperfecta around the country, they've been able to direct a lot of them towards us so that we can be able to administer the zoledronic acid to them. And so in the 10 or so years that it has been, we have been able to recruit about 74 patients into the program. One challenge we have is that not everybody sometimes shows up for clinic. So we currently have 62 patients who are active in the program. And in the last 1 year, we have been able to enroll 11 patients into the program because as more and more talk about it, then we're able to get more patients coming in. And some of the differences we are seeing are even just the reported fractures. Now, this is anecdotal evidence, but when you have only 4 out of the 62 who are in the program reporting fractures within the last year, that is a significant difference. Now, it's true there are those who will not come to us, and so they may not have been reported to us, but it's still a significant change from what we had been seeing before. And what happens to them after they leave our clinic? We'll usually send them back to where they came from. So those who had come from Cure, we'll send them back to continue follow-up by the orthopedic surgeons where they were going. We have a program where there is a school for the disabled that is here. There are not many schools for the disabled children in the country, but one of the big ones in the country is just a few meters from the clinic. And so we usually do a clinic there every term, so about 3 times a year. And we'll see the children from that place. And when these children go back to these places, they're able to continue seeing the doctors and they have access to physiotherapists. One of the questions that was asked in the chat was, how can we be able to do cost-effective physiotherapy for this patient? And the reality is, one way or another, it has to be subsidized or funded. And so for the children who go to the school for the physically disabled, we have a partial funding that helps to take care of the children who are there. The children who come to our clinic, we have some funding that can help to reduce the cost of physiotherapy at the clinic. And Cure also has a similar kind of program. So the reality is there has to be some sort of a subsidy to make sure that the physio is effective and that they come. And so what have been the challenges over these 10 or so years? The biggest one is compliance. Of our 74 patients in the program, of the 62 who are active in the program, 34 of them missed some sessions last year. And so, of course, you know that if they miss for 2, 3, 4 times, when you've had 2 years of no drugs, the rate of fractures starts going up. And the main reason for missing sessions, a lot of it has to do with finances or difficulties in accessing us. This child who is here in the picture with the mother takes about 3 days to reach our clinic. They get fundraising from the church to finance their transport. They'll travel and have to spend 2 nights somewhere on the way to be able to reach us and reverse that same process going back home. So if this child needs to come 4 times a year because they're less than 2 years, which means we're giving them drugs every 3 months, you can imagine the difficulty that happens. And so when they miss a clinic, we can't be too harsh on them because we understand the challenges they are going through. And the same thing happens when the caretaker is not available. The same thing happens when a fracture occurs. They will not come to the clinic. They'll usually just go to the hospital that is near them. The other challenge has been making the program sustainable. So over time, we have found, as Dr. Lucia said, we have zoledronic acid in the country. But unfortunately, it is only at least within the Ministry of Health, it's only in the formulary for the purpose of treating cancer pain. And so the private pharmacies or the private drug distributors who bring it do not have such a big market. And so they are not as reliable in bringing the drug. And so that's one of the things that we've been working with the GPED and JP over time to see how we can get this drug more available in a reliable way so that the program is sustainable locally. And the last thing has been awareness among patients. Among the stories that I'll be sharing, one of them is of a child who stayed for such a long time without getting any treatment because they just did not know that there was access to bisphosphonates in the country. And we've had children who have come to us in their teenage because all the other years before, there was just no awareness that they can actually get care elsewhere. And so to try and improve all these challenges, we have these strategic initiatives that we keep pushing towards. The first part of it being we need to improve access to drugs and the implants. The drugs being bisphosphonates, and over time, these are different partners that we've been able to work with. The BC Children's Hospital, there's a hospital in Korea, GPED, and the health volunteers in Canada. They've been able to get us these drugs, at least to start off the program. But then these children also need surgeries, and it tends to be expensive. And so different other partners where our clinic is part of it, Cure is part of it, and others, we help in ensuring that the deformities are corrected, but within reasonable expenses. And the second part of this strategy is improving the awareness and affordability. And so we reach out to different groups that have access either to the patients or have access to the health workers to ensure that more and more people have been told about this osteogenesis imperfecta. And that's part of the purpose of this presentation today and this meeting today, to just increase the awareness among the various groups. And finally, all these different partners, we are working together with them to improve affordability of the whole process of treatment. So let me share a few stories. Now, obviously, if I was to give all the stories, the meeting would not end anytime soon. So I'll just pick 3 and get to talk about them. Here is a story of hope. Amos was diagnosed with osteogenesis imperfecta reasonably early, but then by the time he could get access to permethrin, he was somewhere around, I guess, 10 years plus. And he had to leave school because the many fractures that he was getting made schooling very difficult. It also made it difficult for his caretaker, who was his mother at that time, to keep bringing him to hospital for surgery and for whatever kept bringing him to hospital. So at some point, the equivalent of grade 9, 10 for many of us around the world, he just stopped school and did not attend school for the next 4 years because the mother had given up on any potential for him being able to get anything good in life because of all these many fractures. And it was during these 4 years that he eventually came to our clinic, and we started him off on permethrin and eventually switched him at the time when we switched him to zoledronic acid. And over time, the fractures reduced, the pain reduced, and the question was, why can't he go back to school? And so he went back to school, and 2 years ago, he completed the equivalent of grade 12. And today, he is studying a finance degree at one of the local universities. That's what happens when somebody has got hope restored. because of the pains and the fractures have gone down. He is one of our success stories. Aslam, we received a call about two months ago from his mother in distress that he had injured while in school. A wheelchair had fallen on his arm and he was in a lot of pain. He was taken to a nearby hospital where he was told that he has a dislocation. Now, as an orthopedic surgeon, I do not expect a child with osteogenesis imperfecta to have a wheelchair fall on their arm and they get a dislocation, because that would mean that the bones are so strong that it's the ligaments that are giving way. So we asked that he be sent to us because we didn't believe that that was going to be the case. We asked that he be sent over to us so that we can see what the issue is. And sure enough, when he got to us, he did not have a dislocation. He had a subluxation. Subluxation being that the elbow joint had moved slightly out of place. So we took him to surgery. We took him to theater, gave him some analgesics to control the pain and check the elbow. And there was no fracture. And the X-ray had already confirmed that there was no fracture. Aslam had been on permethrin and had switched to zoledronic acid and had been on this for at least 4 years. So we had progressively seen his bones getting stronger. And I don't remember us doing surgery for him for a fracture for at least the last 2 years. Incidentally, he is scheduled for surgery tomorrow or the day after tomorrow because the implants, the metal rod that was in his bone has grown short and now it's giving him trouble, and he fell recently and now broke the bone below where the rod is, which is a normal thing that we expect, even in people without osteogenesis, that if you have an implant in the body and you injure that bone, you're likely to break below. And so he is a story of the strength that we tend to get in the bones because of using the zoledronic and the permethrin. And then finally, Boniface has been with us for more than 8 years. Actually, the 2019 is not when he first came. I think he first came to us in 2018. And we have walked with him the journey. Unfortunately, he has severe osteogenesis imperfecta, and so he already has scoliosis. He has the Wormian bones. Both the lower and the upper limbs are. But because of continuing with the medication, we have now reached the point where we are no longer talking about doing surgery for fractures, but we are now doing surgery for correcting deformities. And so recently we had surgery, we took him for surgery for his upper limbs, which had been deformed for a very long time, but we had always not wanted to do surgery on him because we thought that there may be a time when he'll come with a fracture, and because of a fracture, we'll end up also doing a corrective osteotomy for one of the deformed upper limbs. And so we have seen a progressive change in him. His spine is still bent, we know that. His upper limbs are weak, we know that. But he is able to continue with school, and we're reaching the point of just now correcting deformities, partly cosmetic, partly for functional reasons. And we can continue telling more and more stories of other patients. A boy who came to us having fallen because he was hanging from a tree because he had seen all his friends hanging from trees because he had got to the point of not having pain. Another one who had joined sports and was representing the country in wheelchair sports because they've been able to go back to their life. And there are many such stories. And so in this time, there are several lessons that we have learned. One, there is proof all around us that bisphosphonates work. So all children should be given access to bisphosphonates at the earliest opportunity. Two, we should start with what we have. This is a picture of me looking for some space at the window to hang the drip for this patient because the drip stand was somewhere away from us. That is what was available. It was working for us. And so we started with that. We started with permethrin because that is what was available. It made a difference. At the point when we had access to zoledronic, we switched to that. We start with what we have. And then finally, create a community. Let these children be able to come together and talk together. At the time when we used to give them permethrin, we used to ensure that we admit all of them in the ward at around the same time. And this is one such picture where they were admitted in the ward, and the one that you see in the foreground talking to the others is a much older one. And he is giving advice to the younger mothers, the younger children. They get to talk together. about their condition, it gets to encourage, including even those who come the first time thinking, oh, I thought my child is the only one in the country with this kind of problem. Finally, to thank you, this is a picture of one of our patients who just completed school last year, is grade 12. And I keep seeing him in town whizzing about with his wheelchair. He is the one who had been involved in wheelchair sports, has been on treatment. He is now over 18. We are not expecting any significant problems for him. So I guess he has already stopped his bisphosphonates. But these are the kind of stories that now make us happy, that somebody is able to continue with his life, even if he's on the wheelchair, but his life still goes on. Thank you very much.
Thank you very much for your excellent presentation, Dr. Nuku, and also for the inspiring stories. And today, we are very honored to have a representative from the Ministry of Health of Kenya, Mr. Evans Fundi Munuva Dixon, who will be sharing the perspective from the Ministry of Health. He's a program lead early childhood development at the Division of Reproductive Maternal Neonatal Child and Adolescent Health, Ministry of Health Kenya. Without further ado, to Mr. Dixon, the time and place is yours.
Good evening, everyone. At the moment, I will not use the video. Yes, and the same note, I received this invitation late yesterday, so I don't have slides, but I really appreciate that this insight of that you're being given, and I want to tie the presentation that has been done with what we are doing at the Ministry of Health. And first, I want to say that at the section of newborn and child health, we have a mission, and that is to ensure survival, health, development, and well-being of all newborns and children in Kenya. So what actually is being done to these children with OIA, it is part and a parcel that makes them to survive and also to thrive. Because under ECD, we want to see every child attain their full potential. So that is actually where I want to tie it. From the presentations, we have understood that these children have special needs in terms of fragile bones that break easily. They also have problems with the dental issues. And even though maybe it may not have been mentioned, we understand they have hearing loss because bones of the ear may be affected. And also, as you have heard from the presentations, they end up with short stature. So for Ministry of Health, in terms of early child development, the points of intersection is first, based on the 5 components of nurturing care for early child development, which is good health, adequate nutrition, responsive caregiving, safety and security, and opportunities of early learning. So in terms of health, these children, we look at them under the category of vulnerable children. And then we look at their health in terms of prevention of they need consistent and specialized medical care in terms of preventing maybe illnesses and diseases, childhood illnesses and diseases. And also, when it comes to responsive caregiving, we are looking at these children in that they may have limited physical mobility and frequent medical procedures. So in terms of responsive caregiving, we give programs that help the children to reduce trauma. Also, we give them programs that promote emotional bonding. And also we ensure that the children feel secure and supported despite their physical limitations. The other area that we also look in terms of our programming is the safety and the environment adaptations of the children. Because of their fragile bones, they require an environment that minimizes fall risk and physical stress. And also, we also create awareness for a safe and natural physical environment that prevents injury and encourages safe exploration and learning, such that we don't need them just to be idle. We want them to learn and to explore, but we have to make sure the environments are safe. Also looking at the opportunities of early learning and stimulation, they have limited mobility. Cognitive and language development should also be actively supported. So in other words, we do adaptive toys for them that they can maybe even play with them at their reach, even with their limited mobilities. We also tailor programs that we make them to have access to books, and also we make sure they have inclusive play activities that can provide stimulation without endangering the child. And lastly, on that aspect is the inclusion and the psychosocial support. We also tailor activities that will give the caregivers the need to support caregivers and other educators so that we can provide or promote inclusive attitudes and also psychosocial well-being for that child. So in a nutshell, that is what we provide for those children. And I picked something from Dr. Lucy, whereby in terms of awareness, since early childhood development starts at 0 to 80 years, that is preconception. I picked that we can add an item of genetic counseling in terms of like if somebody is preparing to get a couple is preparing to get a child. I think as we do our awareness in our programs, we will pick that item of maybe people can go do genetic counseling in aspect of whether they are carriers or something like that. So I really appreciate, and I believe that this is just a start. We shall continue to interact with those who are nearer to us because we go mostly around Kenya creating awareness through documents that we have, like as advocacy strategy. We also have another document, SBCC, and also we are developing our integrated early child development policy. So through this, we can continue reaching the caregivers at every corner through our partners and also our healthcare providers who are on the grassroots so that we can increase the coverage of awareness. Thank you very much.
Thank you very much, Mr. Dixon. And then we will continue with the discussion. But before discussion, we want to thank Fresenius Kabi, the pharmaceutical company that made a generous donation of zoledronic acid. We also thank Health Partner International, a Canadian NGO that organized the donation with GPED. The success could not have happened without them. So thank you so much. And we will begin our discussion session. Okay, so we will give a question for the presenter. So I think this is for Dr. Maria Eve. Can you please elaborate how can you adjust the DEXA Z-score with height Z-score? Is there a software or normogram?
Great question. It's even more simple than that. So when you have your height Z-score, it should be around equal to your DEXA Z-score. So for example, if your height Z-score is -3, your DEXA should be about -3. We always kind of allow for about a 2 standard deviation difference. So we say like it should be around the same, plus or minus 2 on each side. So if you have a height Z-score that's -3, your DEXA should be between -5 and -1. But bottom line, it should be about the same. So no fancy technique, very, very straightforward.
Okay, thank you for your question. And the next question, please, Arneta or Anis? Yeah. So this is the question from Sabine Khan. For how long zoledronic acid should be avoided after surgery?
So answer is 4 months. That is only when you have a surgery on which osteotomy has been performed on the bone. So Dr. Nugu knows that more than me, but when an osteotome has been used and the bone has been cut, you're at risk of non-union when you're on bisphosphonates. You're at risk that those two ends never heal. And that's when you want to hold your bisphosphonates for 4 months. If you had a surgery where it was only, for example, there was a fracture, there was a cast applied, even if it's in the surgery, or even if they had a replacement of a rod, if the bone was not cut, you don't need to hold. So it's an osteotomy. So if you had a fracture, still give your bisphosphonates. So we see actually a lot of people holding too much. So it's really after osteotomy, 4 months.
Okay, so thank you so much. This is very important for our clinical practice. Yeah, the next question, please. So this is the question from Ratih from Indonesia. How the indication zoledronic acid before or after surgery? And can the baby using cast for the fracture one?
So
Maybe this is, yeah.
You don't need to hold bisphosphonates prior to surgery more than 24 hours. Bisphosphonates stay in the blood for 24 hours. It goes straight to the bone. So as long as you have this 1-day period between your dose and your surgery, you're fine. You don't need to hold it before. Afterwards, that we said is 4 months after an osteotomy. And for the second fracture about the cast, yes, you can use casting. Again, like Dr. Nuku may be better able to talk about that. But the key is to use very light, all right, because they have a poor muscle tone, often, especially in severe OI. So you don't want to use a heavy cast. So you want to kind of do that gently. So feel for Dr. Nuku to add anything to that for the second question.
Yeah, please, Dr. Nuku.
Yeah, I can add. As a general rule, children who are less than 2 years, we tend to use casts. Children who are older than 2 years, we may consider doing surgery. And so you're right, Marie, in saying that for as long as it's not a heavy cast, you can be able to apply a cast. And the good thing is that nowadays we even have fiberglass casts, which are way lighter. I usually tell my patients that a fiberglass cast for the whole lower limb is as heavy as your phone. So we can use casts for even those infants.
Okay, thank you so much. And the next question. Can bisphosphonate be given in malunion or fracture in OI patient? Dr. Maria Ifer.
So the definition of malunion is when you have bones that are not aligning more than 12 months afterwards. When you have malunion, there's not much you can do afterwards that is medically, right? So bisphosphonates, you could still, so if a child unfortunately had malunion, you could still continue giving bisphosphonates for the other bones, but it will likely not change anything for your malunion. Even when you do your holding bisphosphonates 4 months after surgery, 41% of severe OI will still have non-union. So you don't completely reduce that risk even when you hold your bisphosphonates. So it's still occurring, it's still quite frequent. Unfortunately, that's one of the morbidity we see in OI that's very hard to treat. Dr. Nugu, I don't know if you have anything to add there. Probably something you see quite commonly.
Yeah, so to use one of my stories, so to use one of my stories as an example, the last patient I talked about, we are now doing corrective osteotomies to correct deformities that have happened for a child who has been having bisphosphonates for the last 8 years. So the bisphosphonates will not change this shape of the bone. If it was healed bend, it will remain bend. If it was healed straight, it will remain straight. So for that, you need surgery. But the bisphosphonates will help prevent a future bowing because of poor bone formation.
Okay, so thank you very much. We still have time, I think. Yeah. So this is the next question. How to offer physiotherapy in a resource-limited setting? This is from Dr. Cheng from Malaysia.
Maybe let me take that up.
Dr. Guku?
Yeah. So I work in a resource-limited setting. Most of our patients come with these conditions are also not very wealthy, and so they can't afford too much. And so there has to be partnerships that you work with. So in our case, we are partnering with a physiotherapy center that is willing to take a lesser fee for the physiotherapy services. 2, we have partnered with somebody who is partially sponsoring the physiotherapy for the patients, and especially the patients in one of the centers where there are many patients with disabilities. And so from what I have seen in my years of practice in orthopedics, for you to offer good care, but at the same time at a lower cost, there has to be partnership with the people who are willing to accept a lesser payment for the same, and people are willing to put in funds into the same. So that's how we have found it working.
Okay, so thank you very much. Is there any contraindication for the physiotherapy in patient with OI, Dr. Nguku?
No, there's no contraindication. Yeah, no, there's no contraindication. We need them to work. The problem is sometimes the physiotherapist may not be aware that this is a patient with osteogenesis imperfecta. And so we've had a few patients come with what we call iatrogenic fractures. We have caused the fractures when you're trying to make a knee move or make an elbow move. So as long as the clinician knows that this is a patient with a brittle bone, there are limits to which they can go. We need the physio because we need the muscles strengthened. We need to move these patients from using wheelchairs to using walkers when it's possible. We need to maintain them being able to walk and not scaling down to a wheelchair. So yes, we need the physiotherapy.
Thank you so much. We still have time, I think. Next question, please. So this is from Keenan. Can osteogenesis imperfecta be prevented, or it is solely genetic? And what are the current challenges in diagnosing osteogenesis imperfecta in newborn period, especially in cases with milder manifestation or atypical genetic profile?
So when we think about the definition of OI, it is always genetic. So it's sometimes we use other terms like idiopathic juvenile osteoporosis. There's a lot of other terms, but primary osteoporosis is always genetic. So you have a genetic mutation making you having bone fragility, as opposed to secondary osteoporosis, which is when you're on steroids or have leukemia and you have fragile bones. So the second question was about how challenging it can be sometimes to make a diagnosis, especially in milder form. So when we think about OI, typically OI, we talk about mutation type 1 collagen, but there's a number of other mutations. There's recessive types of OI. They all have very different profiles. So sometimes it can be tricky, but even if you don't have genetic testing, if you have a case of bone fragility and you don't have a secondary cause of bone fragility, most likely this is genetic. So if you excluded all your diseases, you excluded that you have rickets, you have a normal vitamin D, normal calcium, it's still most likely genetic. If you would want to have the exact mutation, then of course you need genetic testing, but you could still say that it's most likely a genetic cause.
Yeah. And the second question, the challenges in diagnosing osteogenesis in infant, particularly if the milder manifestation.
Yeah, I mean, it's similar to that, right? Like whenever you have an infant that has a low trauma fracture, if that infant has a normal calcium profile, normal vitamin D, no other cause, you can make the assumption that most likely this is a case of primary bone fragility. Now, if you're really not sure, what will tell you your answer is follow-up. Any cause that is genetic will not get better, right? So you will see in follow-up that the DEXA has plateaued, that the child has not accrued bone as they should. So whenever I have those cases, or if child abuse was questioned, right, and I'm like, I'm not sure, I have a normal genetic profile, I follow up, and that will tell me my answer. So at 1 year, I look at how much new bone has been formed, did the DEXA improve? Usually in OI, you'll see flattening of that DEXA.
Okay.
The other cue is vertebral fractures. Whenever you have vertebral fractures, and if you don't have a secondary cause, this is OI most likely.
Okay, thank you so much. The next question, please. Yeah. So you said that the treatment should be continued till the end of growth. Do you mean that adulthood prevents them from fracture and pain?
That's a great question.
Yeah.
The bone is more fragile when it's growing. because any newborn is creating this shift where you have more fragility. By definition, children will always fracture more than adults. If you look at the curve of fracture rates in OI, it's high in infancy, goes down, goes up in puberty, and then kind of plateaus and goes down in early adulthood, and then peaks again around menopause or andropause. So usually the young adults and even like midlife, they're not fracturing very much. That's going to go up after. That's because you're no longer growing. We have shown that when you treat bisphosphonates in childhood, if you stop bisphosphonate at the end of growth and you follow those adults, we have shown that the gains are preserved for at least 4 years. So even when you stop, their DEXA is still good. They don't have more fracture. Pain is a different story. A lot of adults still have pain, and sometimes I prescribe bisphosphonates for pain, even if adults don't have fractures. And that's because pain is really responsive to bisphosphonates.
Okay, thank you very much. We still have around 8 minutes. Next question, please. What are the available, affordable, and effective bisphosphonates in most resource-constrained setting? This is from Dr. Elizabeth from Nigeria. What is maybe Dr. Nguku also can answer this.
Yeah, since I'm in a similar kind of environment, let me give the figures that we have in Kenya. Zoledronic acid is available at about $35 per vial. That $35 in children, we can use it in about 4 children in the same sitting. We tend to group our patients together when they come for zoledronic acid. And so instead of using 1 vial on 1 child and then throw away the rest of it because we won't use the whole vial, then you can get to use on more. So that currently is the most cost efficient. Pamindronic acid, pamindronate, has availability on and off, but it tends to be more expensive. When we last bought, and that was, I guess, just after COVID, we were buying at about $90 per vial. And the bigger the child, the older the child, the more volume they use. And so you end up realizing that just vial for vial, you end up using more on pamindronate than zoledronic. And then price to price, pamindronate is more expensive than zoledronic. And so I'd recommend zoledronic any day if you're considering a resource-constrained area.
Yeah. We also have the same experience in Indonesia, Dr. Nguku. We ask several patients to come together in a day, so we can use 1 vial for several patients with zoledronic acid. Yeah. The next question, please. Could you elaborate about timing of bisphosphonate in a child with OI and an acute fracture or open complicated fracture? This is from Naina Bhatt.
So you never want to delay bisphosphonates. You give it.
Okay. So I think this is a very clear answer. And the next question, please. In a preterm neonate with multiple femoral and humeral fracture, along with a low vitamin D and calcium level, how do you differentiate between osteogenesis imperfecta and metabolic bone disease of prematurity? Dr. Maria, if maybe you can answer this.
Yeah, that can be very tricky. Usually you want to treat secondary cause of bone fragility before making a diagnosis of a genetic cause. So in this setting, I would say treat the calcium and the vitamin D deficiency, treat like if it's a metabolic bone disease of prematurity, and see if there's an improvement. And if not, you could have the 2 disease, right? The metabolic bone disease of prematurity plus the OI. It also depends on the severity as well of the phenotype, or if there was, for example, in utero finding, right? So if you had in utero finding, or if you have vertebral fractures on top, then you might have the 2 conditions. But if you only have long bone fractures and you have those settings of abnormal blood work in a preterm, I would say it's most likely metabolic bone disease of prematurity. Treat that first and then see if you have OI in addition to that. You don't want to give bisphosphonate in setting of low calcium and low vitamin D. You can cause harm like this because you can cause severe hypocalcemia. So even if you don't have the right diagnosis, don't give your bisphosphonates right away, right? Treat the calcium and vitamin D deficiency first.
Okay, so thank you very much. And we still have 4 minutes. Next question, please. So for Dr. Maria Eve, I have question. If you diagnose OI in intro, there are a role in giving the mother zoledronic acid to reduce the risk of fracture? Is there any danger to the neonatus, newborn or fetus?
Yeah, that question comes from time to time. There has been instances of bisphosphonates given to pregnant women before we knew the woman was pregnant, and there was no adverse outcomes. That's important to say. There was no study of use of bisphosphonates in pregnancy. We can know for sure, but it appears to be safe. There are some individuals, and I have seen that have tried to give 1 or 2 doses of bisphosphonates to mothers. They are reporting potentially some improvement in the fetus. So I have never done it myself. It's quite, but it's experimental, but it has been done. And I think it's a very important question for future research.
Okay, thank you so much. And the next question. Several of my older patients want to have children. What is your experience? Do they eventually have children? In OIFE, they say that it's possible and delivery is by cesarean. What happened in other countries? Maybe Dr. Maria have experience with this.
Yeah, I have lots of my patients that have severe OI that want to have kids. It is possible. It's not clear. So most of the time when the mother has severe OI, most of the time they'll need a cesarean section. But just an apartheid that in an affected mom, even if you have severe OI in the fetus, it is not clear if vaginal or C-section is better, because there is also risk for fracture in a C-section. But if the mom is affected by OI, typically it's going to be a C-section. The really important key is to avoid instrumentation. So if it's a vaginal delivery, for example, in the case of an affected fetus, by a non-affected mom, very important to avoid vacuum, avoid forceps, because you could cause rupture of the vein of Galen. You can cause severe cephalhematoma. So that's very important. But yes, they can have children. It's possible. Lots of important follow-up with maternal fetal medicine if that's accessible. And I would invite you to reach out if that's the case. Like, I'm happy to help as well, provide feedback virtually too.
Okay. So thank you. Maybe we can still have 1 or 2 questions. Could
This
you
one we've
elaborate
done.
about timing? I think this is almost the same. Yeah. Could you elaborate about timing of biphosphonate in a child with OI and an acute fracture or open complicated fracture?
Yeah, we've had that one. So give it, don't wait.
Yeah. Okay. Next question, please. The drug being used to manage OI seems to merely minimize fracture. I have never had the injection, and neither have I had fracture in 2 years. Is it still necessary to have the drugs? Dr. Maria.
Yeah, so I assume that that's probably an adult. So most there's that period of sweet spot in young adulthood / mid adult that people don't fracture. So you don't necessarily need to have bisphosphonate at that time. Now, depending on your DEXA score, sometimes we would still prescribe other drugs, and there's new agents like anti-sclerostin antibody. There's other things that could be given. So we would need to have kind of more detail of the case. I'm happy by email to help if that's needed.
Yeah. So one more question. I think this is the last question. Surgery seems okay for patients whose deformities are severe but not to enable mobility. If my deformities are not extreme, would surgery serve any purpose? Dr. Nguku, maybe can ask this question.
So we do surgery for various reasons. Reason number 1, and the commonest, is the child has come or the person has come with a fracture. And because they already had a deformity, we take advantage of the fracture to also correct the deformity. The other reason would be because of a deformity that is causing another problem. So you'll notice we tend not to do much surgeries in the upper limb because, yes, they have deformities, but they tend to still be functional. But deformities in the lower limbs, severe bowing, also limits ability to walk. And so we'll do surgeries at that time, not because they had a fracture, but because we want to improve their ability to walk. In this case, if we do surgery for somebody who has a significant bow, 1, we reduce their risk of fracturing, because when there's a significant bow, when pressure is applied to that, the chance of breaking is higher. And they also tend to have more pain around the tip of the bow. So for those, yes, would still go ahead and do the surgery, and it can help in getting them to walk.
Okay, so thank you very much for your answer. And thank you very much for this fruitful discussion. As we wrap up, I want to thank each and every one of you for joining us on this special Wishbone Day seminar. A huge thank you for our incredible speaker and panelists, and to all of you who are committed to improving the life of children living with osteogenesis imperfecta around the world. Please stay connected with the GPED for future webinars, collaboration, and initiatives that bridge global gaps in the pediatric endocrine care. Happy Wishbone Day, and let's keep raising awareness and advocating for every child right to thrive. And now I will give the time to go back to Arneta.
Thank you very much, Dr. Agustini. Once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all speakers, moderators for the incredible lessons and insights we have learned today. Of course, no event is complete without a photo session. We now invite our honorable guests, speakers, and moderators to once again turn your videos on to take the group photo. To all the participants, please turn on your videos as well. We will take a group photo with all our distinguished speakers and guests. Let us wait for a few seconds for people to turn their videos on. I will now be taking a picture. 3, 2, 1. 3, 2, 1. With all the participants as well. 3, 3, 2, 1. 3, 2, 1. 3, 2, 1. That concludes our photo session. To all our participants, please fill in the feedback form that has been shared via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Global Pediatric Endocrinology and Diabetes also conducts routine webinars as well as other very exciting opportunities and activities. And exciting news as well. Following the success of the first GPED annual meeting last year, we are proud to share that the second GPED annual meeting will be conducted on the 29th to 30 November and 6 to 7 December 2025, with the exciting theme of optimizing pediatric endocrine care in resource-limited settings, bridging assays, technology, management, and clinical practice. To keep yourself up to date, we urge you to follow GPED on our social media platforms as detailed on the slide. Furthermore, register to become a member of GPED via the GPED website as seen on the slide. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.